All right, good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's topic is on dialysis access considerations in kidney palliative care. And to help us with this, we are honored to be joined by the two co-authors of a recent paper that was published in 2023 in Seminars of Nephrology. First, we have Dr. Samantha Gelfand. She's a dual board-certified nephrologist and palliative care physician at Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston. She's the director of the Kidney Pal Outpatient Program, where she provides decision support, symptom management, and conservative kidney management for seriously ill patients living with kidney disease. Welcome, Sam. And second, we've got Dr. Dirk Henschel. He is the director of interventional nephrology, Brigham Health at Brigham and Women's Hospital and Faulkner Hospital. After his nephrology fellowship, he trained in interventional nephrology in St. Louis, Missouri. The Brigham Health Dialysis Access Program currently serves dialysis patients in and around Boston and New England and receives referrals from over 50 dialysis units in more than 6 states and performs over 2,500 endovascular procedures annually. So welcome, Dirk. Our plan for today is going to be a presentation, and then we'll have some time at the end to pick our two guests' brains as much as we can. So I will hand the mic over to you two folks.
Thanks so much, Marty. Thanks for having us. We are going to try to give a broad overview of some of the central parts of kidney palliative care and how it relates to how we think about dialysis access and dialysis-related decision making. So I'll just jump right in because I think time is of the essence. First of all, what do I mean when we say kidney palliative care? I specifically mean that it refer to an interprofessional team that in some form has either experience, dedicated education, or an embedded model within nephrology. So I'd say that I emerged from palliative care fellowship without a significant amount of experience with patients with advanced kidney disease. And so kidney palliative care essentially can be thought of as a subspecialty of regular palliative care where the clinicians have heightened awareness of the particular challenges faced by patients with advanced kidney disease. Like all palliative care, it's aimed at sort of helping people live as well as possible with their advanced illness. Specifically, it involves managing uremic symptoms and trying to help people navigate complicated decisions. And it definitely is applicable to people of any age on any treatment modality. So whether that's AKI in the hospital, deciding about a trial of dialysis or not, CKD patients, people already on hemodialysis or peritoneal dialysis, as well as transplant patients, are experiences that all of those groups have palliative care needs. And then Marty asked me a great question, which I thought was helpful to go over, which is like the differences between kidney palliative care and general palliative care. I think there are several, but the main ones are people with advanced kidney disease really experience the same severity and frequency of symptoms, but different symptoms than patients with advanced cancer. So that means that they're all also different symptom management tools that we really don't use all that often in palliative care for cancer patients. Things like diuretics and IV iron and EPO. Those are very common palliative care tools for these patients that I don't think we get much training on in general palliative care fellowship. I think there's different types of serious illness communication, mainly that we actually did a little research letter in kidney medicine a few years ago showing that when a kidney palliative care team is present, it's more common for the discussions to focus on kidney failure treatment options like dialysis or no dialysis, whereas when it's a general palliative care team, I think the discussions often have more to do with the broad advanced care planning, things like code status, goals and values, but it actually doubled from when Kidney Pal started at our hospital system. We looked at all the PalCare consults for kidney failure patients before that, and about 20% of those talked about dialysis decision making, and after Kidney Pal came on, it was 40% of those conversations were about that. There are different challenges in prognostication compared to cancer care. Cancer you can usually visually see is progressing, whereas I think debility is the main thing that progresses among patients with kidney failure, and it's much harder to quantify. Um, More on that later. I think there's different triangulation, meaning when I'm a palliative care clinician working with an oncologist, that's a certain type of relationship that I'm respecting and that I'm involved with, versus when I'm doing palliative care for a patient with kidney failure, the nephrologist might be in clinic, but it might be in a dialysis unit, and that's a different type of relationship that the primary clinician has with the patient. And then lastly, it's important to mention just the population. In the US, the people who have kidney failure are much more likely to be older, to come from a lower socioeconomic status, and it's 4 times more common among Black patients compared to white patients for mainly genetics and, social determinants of health and structural racism and things like that. So for all those reasons and more, it does feel like it's a different or at least a subset of general palliative care. Moving on, so just a few quick examples. You know, the Kidney Pal team is at Brigham, like Marty said. We see a whole range of people, everything from relatively young people who are waiting for a liver kidney transplant. We manage this lady's pain and pruritus. Onconephrology cases are common, and then failing kidney transplant allografts among people who are not going to be candidates for retransplantation, don't want to resume dialysis. Those are people that we're often talking about the option of conservative management. I'm going to spend just a minute on that because it's not all that well taught or discussed. Conservative kidney management is not just the absence of dialysis, it's actually 4 discrete sort of interventions going from the top clockwise. Conservative kidney management is CKD care. It's medical care aimed at preserving kidney function for as long as possible. It's advanced care planning, goals of care discussions, thinking about the what ifs of the future. The bottom, it's definitely psychosocial support for not just patients, but also their families. And then it's symptom management focused on the most common symptoms of uremia. A quick example from our practice, this is Miss L, who came to us saying she was told she needed dialysis. She did not want to start dialysis. She had cardiac amyloidosis and stage 5 kidney disease, GFR of about 12, and mild uremic symptoms, fatigue, some taste changes, and edema. Goals of care conversations with her made it, she was like very, very clear. She wanted to be at home, not coming in and out of the hospital or dialysis unit. She wanted unrestricted diet, and she wanted her family to have support. The procedural part of it for her was the most important thing. She did not want to undergo any surgeries or procedures for dialysis access or anything else. She wanted to minimize medications, and she wanted to have a peaceful and quote unquote natural end of life. So what did we do for her? Conservative management for this patient involved me as her nephrologist managing her antihypertensives, her diuretics, and IV iron for fatigue because she had profound anemia. She had a liberal diet. We used some topical rinses for her taste changes, and we selectively deprescribed her list from, 19 meds is the average number of meds that a person on dialysis has to take every day, and we were able to whittle it down to about 6 meds. She underwent no procedures, and we did a lot of outpatient psychosocial support for her. So that's an example of, I think, the central take home of conservative kidney management is that we sort of think about treatment options for kidney failure in a slightly false paradigm, which is transplant is best. You should try to get a transplant. If not, there's dialysis, and there's a lot of modalities that could suit you. But if you don't do either of those two, then I don't know, maybe it's sort of like doing nothing or giving up. This is a very common feeling that people, especially clinicians, have, even when they're worried people won't do well on dialysis. I would argue that these are the real care options for patients who are over 75 who have chronic kidney failure. Many are ineligible for transplantation. And then when you're comparing dialysis and conservative management, it's important to sort of be comparing in terms of the things that patients care about most, not just survival, but also how much time they are going to devote to their medical care, how many procedures, what's their function status, and their symptom burden. I want to just accentuate that this is chronic kidney failure. I don't mean to say that people with AKI, meaning acute kidney failure, and say 0 urine output in the hospital, if you don't start dialysis for those patients, they live hours to days, not months to years. So we're talking about people with chronic, slowly progressive CKD. And I'll just very briefly show you some of the data we have on survival with conservative care because it surprises people. We're sort of subconsciously taught that if your potassium is 5.5 to 6, something very bad is going to happen to you within minutes. And of course, that can happen. But overall, survival with proactive conservative care, like I just described for our patient, is on the order of months to years. This is data from different observational cohorts for the last 20 years showing that, survival matters on where you start measuring survival from, but even in the most sort of strict measurement where the eGFR the measurement started when the GFR was below 10, those patients on average are still living 6 to 12 months after they would have started dialysis otherwise. People who do dialysis typically live longer, no doubt about it. In most studies have a similar pattern to this study, which showed that people who opted for dialysis, these are people who are over 75 in the UK, they lived more than twice as long as the people who opted for conservative management. However, I think the rub is how is the added time spent? And the truth is that a large amount of that added time is spent at dialysis or in the hospital with access or other dialysis related complications. I use this as a litmus test with some patients. This does not tell me who should get dialysis and who shouldn't. Some people look at this and they say, oh my God, I lived more than twice as long. Give me dialysis. There's no doubt about it. Those people have a longevity focused value. Other people look at this and they say, well, if a lot of my time is going to be involved with dialysis, it's just not for me. I'd rather have shorter time and have it be at home. I'm going to skip that just for time's sake. Age influences the relative risk of death versus ESKD, so it's not easy what nephrologists are trying to do, which is prepare people for dialysis for those who are most likely to actually need it and want it. So briefly, like if you just look at the y-axis here, if you take the GFR of 10, the risk of that person with the GFR of 10 needing to start dialysis or experiencing a life-threatening complication without it is high up until age sort of 85 to 100, when the risk of all-cause death is higher than them like needing dialysis. So take home being that the older the patient is, the higher likelihood that they will pass away from something else before developing the need for dialysis. And that sometimes can influence how the risk benefit of putting a fistula in somebody is if their actual prognosis overall is quite short, they may not live long enough to need that access. But this is a very vague, not it can't predict for you on an individual level. I want to make sure to give Dirk plenty of time. There's plenty of data that for patients with advanced CKD and advanced age that living longer is not necessarily their top priority. Maintaining independence is. And most providers don't actually know what their patient's top priority is if they don't ask. In this study, providers were able to identify the top priority only a third of the time. So we have a bit of a survival bias or assumption in medicine in general, and it may not be what patients actually prioritized. Function with conservative care can be pretty good. It can be pretty preserved up until the last month of life, whereas function among people who are already quite debilitated who start dialysis tends to decrease rapidly. And symptoms, I'll just say real quickly, are very common in both. So kidney failure as the illness causes a high burden of symptoms. Those symptoms occur whether you do hemodialysis, peritoneal dialysis, or conservative management. Which symptoms are the most bothersome can be different between the two groups, but symptoms are pretty heavy in both, and both groups need like symptom-focused care. Symptoms have been shown to decrease consistently with conservative care over time, so I won't go into the details, but there is a lot out there on how to manage itching, how to manage taste changes that many people feel like, well, you need dialysis. There's actually a lot of non-dialysis ways of managing those things and improving people's quality of life. So that leads us to one of the first one of the very earliest decision points with a patient who has advanced CKD in clinic is what kind of dialysis access is going to fit them best if they do plan on doing dialysis. So I'll pass it to you, Dirk, to discuss this, since this is definitely your area of expertise.
Well, thank you so much, Sam, and I apologize to everyone on the call for my financial disclosures that have nothing to do with palliative care at all. They're all device related, and they've really, but it's just, I guess, the laws of the land. So dialysis access, the reason that we're talking about it, it's kind of a complex discussion. I think Sam and you know, that a lot of people have thought about this. If you want to advance one slide further, you know, the decision point to talk about dialysis comes up because the preferred dialysis option, which is arteriovenous fistula creation, in this population takes about 12 months to create in terms of having a functional access. And so you basically have uncertainty of progression of disease, and you have also, you know, fistula failure rate, which depending on the system that you're in, can be as high as 50 to 70%. So we locally have a 10% failure rate. Other places have 50 or 70% failure rate. And so if you then have an 80-year-old or 85-year-old patient and you're suggesting, okay, you're approaching dialysis, you need a dialysis access, then the discussion is, well, this is not a gallbladder surgery where the gallbladder is out or not. This is a surgery where we can flip the coin, and that creates obviously a lot of questions around, should we really progress with this? Do I go through with all these procedures where I may need rescue operations? The alternatives, having a graft placed, those device accesses have a very high failure rate that's built in, because at the venous anastomosis, there's often a stenosis that forms relatively reliable within the first 3 to 4 months after placement. So if the choice is to say, well, we wait until you need dialysis and we then place a graft, then that would be the way to go for the use of a graft. Now, why don't we always use grafts in this population? Well, there are 80-year-olds that still have a mean life expectancy of 8 years if they weren't on dialysis. And a graft usually in the old days lasts 1 to 2 years. Nowadays, with a lot of maintenance, often they last 3 to 5. But the risk profile for nutrition, for other causes of morbidity, mortality, are better for a fistula. So, and then lastly, central venous catheters are the option that is immediately available, immediately usable, but they're also associated with kind of infections as well as long-term consequences for central venous patency, which in this more aged or possibly population with limited life expectancy is a reasonable choice. And the guidelines recommend that everyone with a life expectancy of less than 1 year should strongly be considered to just stay with a tunneled catheter. But as we're talking about patients, I always recall this one patient, 50-ish-year-old woman with multiple myeloma who had to start dialysis. The email conversation between the surgeon and the oncologist was, what's the life expectancy? Oh, 1.5 years max. And 7 years later, she's still using her graft that we're kind of maintaining on. So I think the challenge in this field is also there's very little predictability. From a systems perspective, I just want to give that thought because I think you as providers of palliative care may be confronted with this in one way or another. There are strong government incentives and payer incentives to have a functional dialysis access at the time of the transition point from CKD to needing dialysis. So healthcare systems are strongly incentivized to create functional dialysis accesses. And that brings with it all these surgeries that the patients are exposed to. And depending on how good your local system is, you end up with a lot of access failure, a lot of additional surgeries. The access itself if it's created in the upper arm, often has a substantial cardiovascular burden to these patients. And not every place is able and knowledgeable to create a form fistula that has a much more appropriate flow for the cardiac reserve that these patients have. So I foresee that there are a lot of challenges coming our way in terms of dialysis access creation and chronic kidney disease, that the guidelines tell us create dialysis accesses in all these patients, and only a minority of them will actually progress to dialysis, and the majority of accesses will pass away with the patient before dialysis is reached. I think that is really the situation that we're in. And for me as a dialysis access provider, I really want to create the access now that does the least harm. We're often willing to create an access that's a little marginal, so we check the box, but we know this is really, this may not be usable, but if the patient makes a decision in concert with the family, with the right providers, then the groundwork of vascular maturation on the arterial and venous side, which takes months, sometimes a year or two in this population, has been done. And so then you're successful relatively rapidly with having a functional access. I think those are my vignettes from dialysis access. Sam, that hit the point that you wanted to make, I think, right?
Definitely. Yeah, I'll just emphasize that it's revolutionary within nephrology that the conversation has shifted to say that actually a catheter may be the best option for our patients who are the most seriously ill, whose prognosis is perhaps the most uncertain, or who are the most ambivalent about whether dialysis is going to be an acceptable quality of life for them. And catheters come with plenty of their own burdens and risks, so it's not an easy decision, but I think it does reflect a shift toward patient-centeredness within the field of nephrology, to actually acknowledge that the fistula first or the fistula only is the best for everyone, because it's just not true.
And having in a system and a dedicated service like the one that Sam and her colleagues have started allows providers like me to have a conversation that actually points towards doing nothing with symptom management as an option that offers kind of a positive way out, which is not something that has been present or available to us here for a long time, and is certainly not the case across the country.
Yeah. No, I find it so common for patients who have received sort of basic education about dialysis to not have been told in clear terms that dialysis involves repeated procedures for access, repeated, a surgery, sometimes multiple surgeries, and then repeated procedures to maintain the patency of the access. And not everybody, but plenty of older folks or people who've been through a lot already really don't want to sign up for something like that. So yeah, I think it's a deepening of informed consent for going down a dialysis pathway, and then the thoughtfulness with which Dirk and his team sort of look at patients' anatomy, look at patients' prognosis, and try to help nephrologists understand their options. It's just been a great sort of collaboration and learning experience. So we should stop and ask for questions. We covered like a lot in, very superficially, but we're happy to chat on any aspects.
All right. Thank you, guys. We'll open it up for questions. And while we do, I'll hit you guys with a few of my own. So over the last decade or so, there's been sort of a growing body of literature examining whether code status affects the kind of care that patients get. And patients who are DNR, are they offered less? Do we make other assumptions? Do you take somebody who is a DNR, and does that influence your decision at all about what sort of access you're offering? Does it impact your perception of their goals?
I guess that's a question. If it's a question to me, then I would say I don't look at code status actually. So it's sometimes noted, but it doesn't. It comes. I mean, my assessment is really, well, how vital does the patient appear? What would they tolerate? are their veins and are their arteries? And if they have significant comorbidities, then the conversations with the family as well as with the referring provider, what has been their thinking of sending them our way, because we have, if you have a 90+% success rate in creating fistulas, you have to find a good reason not to do it. But we have learned from doing studies in this population where we present then successful creation of very complicated fistulas with a 25% mortality rate of the patients. And then the audience is just like, yeah, can't you see that these people are all going to die? And that is, it's just that, coming from a point where you take the patient's desire into account, and patients often cannot predict how ill they are as well. And there's a strong culture of prolonging life in many instances, and having the education of talking about other options and quality of life and bringing that to the forefront, I think is really something that needs to be brought into that conversation at the time.
I'll also add, I think that's exactly right. When I receive a patient or meet a patient who has already made a decision in advance about code status and has chosen to draw a line of I don't want to go through those interventions, I usually ask them what brought them to that decision, what informed that decision, and if it has to do with not wanting to be proceduralized or medicalized, or like the distress of a physical intervention like that, I think it's a jumping off point to discuss, well, would repeated procedures, both access related and just dialysis itself, does that also fit in that bucket for you? Or is it more that you just thought at the very end of your life you don't want to go through those things? So I use it as a point of exploration, but I wouldn't say that it directly influences my sort of assumption of what a patient would or wouldn't want.
Lovely. What are your thoughts on cystatin C? Because you mentioned quite a bit in your paper about how estimated GFR based on creatinine is not particularly great, especially in our palliative population. We got loss of muscle mass, older age, lots of comorbidities. I've never ordered it. I've never seen anybody ordered it, but I do see that there's quite a bit of literature coming out on the use of it. Are you using it? Do you recommend we consider it?
Yeah, we're using it. I'd
Yeah.
say just
Hmm.
in the last 5 years or so, it's become a routine thing within the MGB system. It's influencing enormous amounts of care decisions, even in onconephrology. If your cystatin C related eGFR is lower, you really do better with a dose-reduced chemotherapy. So the implications are very, very broad. I also think it helps a little bit because in the past, in the way past, we used to initiate dialysis at a certain GFR, whether you have symptoms or not. And studies over time showed that that just puts more people on dialysis for longer, but it didn't improve outcomes. So practice shifted so that now we try to wait to initiate dialysis until somebody has a uremic symptom, volume overload, or some sort of metabolic electrolyte derangement that could be life-threatening. And that uncertainty of when that's going to develop is very, very high. Some people don't have any uremic symptoms at a GFR of 11, and others have them at a GFR of 15. So the cystatin C for our group functions as another data point. If it's the same as the creatinine-based GFR, then you don't need to really follow it or check it. But if it's significantly lower or significantly higher, it does influence how we're thinking about the timeline for what they're going to need.
And there certainly is quite a bit of evidence out there that suggests that there can be a big difference in certain populations. I checked yesterday just to make sure I could order it in Epic. I can, but I have not yet. So something to try maybe this next week. I think we've got time for maybe just one more question. So you talked a little bit about ambivalence, these patients that are waffling and uncertain. Do you have any pearls of wisdom about how to approach this particular CKD population with their ambivalence?
Yeah, I have thoughts, but Dirk, I'm happy to.
Well, so I mean, in terms of access creation at this first decision point, I think acknowledging that there is the ambivalence, I think, is a first step, and explaining to the patient, well, the fact that you make a decision to have a fistula does not mean that you have to start dialysis. There's a subpopulation of patients that actually experience kind of a slowing down of loss of renal function with a functional fistula. As long as the fistula is not overly large. So there's always a little bit that one can mention there. So at that, if there's ambivalence from my perspective or in my position, what I usually say is that there always are these three options: to proceed with a fistula, to really, or two options, basically, to proceed with a fistula or to do nothing, and that can be an active decision. But that having the fistula itself does not mean to have decided to go forward. And so I leave it at that and try to just make it an opening of a thought process.
Yeah, I think ambivalence is extremely common, and the vocabulary of ambivalence is hard to decode sometimes. Almost everybody says, I don't want dialysis. And it's our job to, I mean, who would, right?
Right.
It's our job to decode whether that means I have goals and priorities that means that no matter what, I don't want to accept that when the time comes, or I'm scared, I want to delay it as long as possible, which is the vast majority of what people mean when they say they don't want it. So that exploration to sort of diagnose the ambivalence, as well as exploration of like mistrust and all sorts of other psychosocial things that can lead someone to be extremely ambivalent or not engage with dialysis preparation. I think that's my approach in the CKD population, because the same words mean very different things to different people.
Thank you. I just want to put in this little comment that was in here because this is very true. So somebody wrote that there's a 24-hour turnaround for cystatin C, and I get that because I think it's not ordered very often. The reagents aren't all that common, and they send them in batches. And probably in a place where you're at, Sam, if they're ordered regularly, it's probably a very different situation than a place that maybe gets one a week or something like that. It might have a lot to do with where you practice and what's available.
I think that's true, but I think the way that a lot of people here use it, you send it once so that you can correlate what's the relationship to the creatinine GFR is.
I appreciate. Okay.
And so then okay, 6 months later, you have this change. The cystatin should change proportionally. You don't have to send it every time, but it gives you that idea, well, the true eGFR is somewhere else. I think the big studies show that cystatin C is much more truthful to the true eGFR than the CRAN.
Thank you. All right, Sam, Dirk, it was an honor. It was a pleasure. We appreciate you letting us pick your brains.
Thank you so much for having us and
Thank
engaging
you.
on this topic. Yeah, thank you.
Absolutely. All right, everybody. Have a great weekend. Bye.